For those of you that I have not met, and I see one place here that I can't put a name to, I'm Bill Crawford. I'm with Genzyme. I'm the Clinical Science Associate for the Southeastern United States for Genzyme. The primary agenda for the meeting this evening was to provide a forum for one of the folks at Genzyme who knows a lot about a lot of things, Bill Pursley, to come and discuss insurance and reimbursement. And I know that many of you have issues that pertain to insurance and reimbursement, lots of questions as to how this affects you. So I wanted to give you an opportunity to hear Bill's presentation. And I don't know if you've met Dr. Neil Weinreb. Dr. Weinreb is the director of the Gaucher Center at University Hospital. And he has a very extensive history with Gaucher disease and Cerebase. And what we're trying to do is direct the primary agenda towards insurance and reimbursement. Once we finish with that, have some questions and answers on that, we'll open it up for Dr. Weinreb or Bill or myself for whatever questions you might have. Bill Pursley, Vice President, United States Cerebase Sales.
Hello. I'm the Vice President of Sales and Marketing for Genzyme, and the major responsibility right now is all Cerebase operations in the United States. I think the number one concern in many people's minds is the cost of this product, and that's something I wanted to address head on. Our commitment right now, the product has been researched, it's available, there's patients on the product. We have about 34 people at the company whose full-time and total-time job, like Bill, Leanne, who is the insurance expert for the Florida area, is to make this product available if your physician deems that it's necessary. We have no other lot in our professional life but to be able to do that. And that's what we're dedicated to. And we have to do that when the concerns are out there like, how in the world do you pay for a drug like this? What happens when my lifetime max expires and I lose my insurance? What if I work for a small employer and that compromises all my co-workers' premiums, or I might get fired? What if I can't afford to pay my copay? What do I do? I mean, these are real-life concerns, and we have basically no business making this drug available if we can't answer those concerns. So that's what I hope to do a little bit tonight. But anything you want to get into, information we have on dosing reduction, information we have on are we gouging you with the price, information on the insurances, etc., that's what we're here to answer. So I don't want to bore you with some numbers, but there's some grave misperceptions out there because of programs like Street Stories. I don't know how many people saw that, or the Good Morning Americas of the world, where there's things that just aren't true happening. And I don't think it's because anybody maliciously is trying to do anything derogatory. I think it's not a very interesting story when everything's running smoothly. And it's a very interesting story if everything's not. Well, the reality is everything is on a reimbursement front. But as far as the media is concerned, that's nothing they're going to report on. And I want to show you so far what we have on the patients that are on therapy. There's about 500 patients in the United States on therapy. About close to 100 of those are on study. 400 of them are not study patients. We have reimbursement information on about that many patients. There's probably about another 150 patients worldwide on therapy. So we have a lot of data on what the reimbursement situation looks like. So the numbers I'm giving you are coming from patients like yourself and your insurance policies that add up to the information. Now, another important thing is the information I'm going to give you has not changed since about the first 100 patients we've had. So there's no reason to believe it will change in terms of percentages. And again, I don't want to get into a lot of numbers and stuff to bore you here, but the bottom line is the overall reimbursement picture is very, very favorable for you. And I don't think it's threatening for you, and that's what I want to get across. A few terms, I'm trying to keep them to as few as possible, that we need to deal with and we need to know about in our own insurance policies that directly affect what the real cost of this drug is to each one of us. One is deductible. The other is copay. The other is stop loss. And probably the most disconcerting for all of you is the lifetime max. Or the lifetime maximum, how much your insurance will cover. And I'll take one of these at a time if I can. Deductible, every single medical insurance policy there is in the world has one. It usually runs from somewhere between about $100 to $250 per patient. And that's simply whether it's going to the doctor for a cold or going for shots or going for Serodase, it doesn't matter. That's what you have to pay before your insurance starts paying. Genzyme can't control that. We can't do anything about that. We can't forgive that. There's nothing we can do about that. That's part of everybody's insurance policy. That's what makes your insurance policy legally kick in, so to speak, to start paying. So that's an issue that hopefully isn't too big of a concern. Now, one thing I want to mention before I go any further. What I'm addressing here, I think, applies to about 90% of you. At least it does with our data. For the 10% that it doesn't apply, please be patient. I'm going to get to some programs at the end of this that will address the needs of those people that fall out of what I'm presenting here. The copay. The copay is the portion of your medical bills you have to pay as compared to your insurance company. Now, except for 96% of the patients, all except 4% of the patients, insurance companies pay either 80% or greater. So in other words, you owe 20% or less of your medical bills in general. But that's not a very good answer for Serodase, because who in the world can afford 20% of what Serodase costs? I can't. My guess is most of you can't. And that's why this becomes a little less important, and this becomes very important. 75% of patients have what's called a stop loss of less than $2,000. Now, a stop loss is the amount you pay out of your own pocket for any medical bill, not just Serodase, regardless of what your medical bill is, until your insurance starts paying 100%. Now, what this is saying, in other words, folks, is 75% of the patients on Serodase will never pay more than $2,000 a year for this drug, regardless of what it costs. Even if we bring the dose way down, even if somehow the recombinant drug is ever cheaper, it doesn't matter. It'll still cost about $2,000 per patient. Now, another 28% have a stop loss between $2,000 and $5,000. Okay? Now, what this is saying then, there's only 2% of the people left that have a stop loss over $5,000. Only 2% of the people that ever go on this drug should pay over $5,000 for Serodase in a year. That's still a lot of money, and I want to address that in a minute. We have one patient to date in all our files so far on an annualized basis who's paid over $5,000 for Serodase out of their own pocket. No one else has. So when you hear stories that this drug is $300,000 and it isn't anymore, and I'll get into that soon, or $200,000, that's not applying to the individual. That's applying to the third-party payer, whoever that may be. And we're going to have programs to address those, and that's what I want you to hold up to get into. But for a lot of us, $2,000 and certainly $5,000 is still a lot of money in a year. So how do we handle that? If for those people here, how many people here are on Serodase? Okay. And how many people know if they get their drug from an organization called PTI? Yeah, Pharmathera. Okay, I'm
They
sorry.
do the billing for us.
Right, okay. Okay. We have an arrangement with them, and it's very simple. They will bill for your Serodase to your insurance company, and the insurance company pays. Whatever your whatever your deductible and your stop loss amount is that you owe, if you can't pay that, they will work out a payment plan for you that suits your needs. That is exactly what they're there for. They're not going to send any collections people after you. We're never going to cut off the drug. What they're going to do is find out if you can afford $25 a month or $5 a month or $200 a month or whatever it may be that fits your situation, and that's what you will be billed. And you will always be billed the full amount, but they will work out a plan that you pay whatever you can pay. So that's how we hope to address those people with the larger stop losses. Okay. The most concerning is the lifetime maximum. This is what happens if I go through what all my insurance covers and run out of insurance and I have no medical protection for anything, not just for my Gaucher disease, but for my colds and my vitamins and my antibiotics, etc. And this is the toughest question. The good news is only 7% of the people, and this is basically almost not just Gaucher, this is pretty general for all people in the country in our insurance policies, have a lifetime maximum less than $1 million. Okay? The good news is 50% of people have an unlimited lifetime max. Half the people in this country that need Ceridase don't ever have to worry about this problem. Now, I'm going to back up here a minute because I think it applies in Florida. About 10% of our population is Medicaid, and about 10% of our population is Medicare on the drug right now. Now, the good news is these people are in excellent shape. Medicaid pays from $1, 100% of Ceridase with no lifetime max. So for the people who are either on a spend-down program or an indigent program, they never have a worry with that. Medicare pays 100% of Ceridase, and about 95% of the people with Medicare, all but 5%, have a secondary policy that pays the other, Medicare pays 80% of Ceridase, and 95% of the people have a secondary policy that pays the other 20%. And again, I'm sorry for all the numbers, and 85% of those have an unlimited cap. The message here is, if you're Medicaid or Medicare, you're in excellent shape.
If that's assigned to an HMO, is that the same?
It can depend on the specific HMO. In other words, there's 5% of the people that don't have a secondary Medicare. Now, to be honest with you, those people will fall in the same situation though. Medicare will pay what they can, and then the distributor will work out with whatever your copayment you can if you don't have a secondary insurance. Now, the reason you have to get billed, and it's hard to say this is confidential information in a room this big, but this is confidential information in a room this big. You legally give up your right to bill a product if you don't bill it fully. You can't collect on that product. In other words, if a company says, I'm going to pay for 80% of that product, and you only make an effort to collect 80%, then they'll say, fine, I'll pay 80% of the 80%. Then they'll say, fine, I'll pay 80% of that 80%. And before you know it, they're paying zero. So you have to show a good faith effort to bill and a good faith effort to collect. So that's why you will always receive your full bills. But your good faith is whatever financial arrangement you can work out with the distributor, with Pharmathera, that you can afford. And so for the 5% of the Medicare people who don't have the secondary coverage that pays the 20%, they basically are taken care of just like these people here. Okay? Now, going back to these categories. On a lifetime max, including the Medicare and Medicaid patients, half the patients don't have one. They'll never have to worry about running out. So that leaves us with 43% of the patients who have $1 million or more. Most of those have $1 million. Probably the general commercial insurance policy has $1 million lifetime cap. And you say, well, if I'm on a drug that might cost $300,000, that doesn't give me a lot of time or protection. And that's a real concern. But what you have to look at is, first of all, the scenario of what's happening now. 56%. In the first year, the dose has been reduced in this patient database I'm talking about, of these 500 people, by 56%, by more than half in 1 year. 77% of the patients who have been on this drug for 1 year have had their dose reduced by half. Now, why I'm telling you all this, if you look at these numbers and you take them over a scenario of time, our worst case scenario patient right now with $1 million cap would take 13 years to run out of that cap. Well, that's still not a good answer, because what are you going to do at the end of those 13 years? You got to be worried about that. And there's one thing that's important to understand here, and I'll keep my fingers crossed when I ask the question to the room. The average man, woman, and child in this country changes insurance policies every 6 years. When you do that, your lifetime max is reestablished. Now, why do we change? Easy. If you're not on Medicare or Medicaid, 90% of us are covered under a group policy, mainly because it's tied into our employer, our ex-employer. In other words, either we change jobs or they change coverage, and we have very little control of that. And so when our policy changes, our lifetime maximum is reestablished. If it was down to 300,000, it goes back up to $1 million. Yeah.
But the Medicare is going to pay 80%.
Right.
Before the supplemental, thank you, the supplemental kicks in. Our supplemental is with Blue Cross of Pennsylvania, and they have a cap. Our cap is like 250,000.
Okay. But are you residents of Pennsylvania?
No, I'm a resident here.
But you have blue.
Right. It's a carryover from when I
lived there.
Right.
Okay. What is, Leanne, do you know what the supplemental Medicare in Florida is in terms of caps?
If you went and attempted to go and apply for insurance, I know of one particular policy, and the lifetime cap, I think, is $500,000 for a supplemental policy that somebody can get.
Okay. And what is your cap in Pennsylvania?
I'm almost certain I'm correct. I think it's 250,000.
Yeah.
Okay.
They have what they call a 65 special in Pennsylvania for the old folks over 65, and they've combined a major medical with the 65 in one program. It's called 65 plus. In the plus portion, there's a $250,000 cap.
Okay. Now, first of all, that's not a real dire picture, because remember, you're only talking about paying for 1/5 the cost of Saturdays. So if you're not talking about that whole bill being applied to that cap, you're talking about 20% of that bill being applied to that cap. So if you are on a decreasing dosage schedule, and I don't know what the situation is, but right now, and there's going to be Greg Grabowski from Mount Sinai in New York, well, now Cincinnati Children's, is about to publish some very strong data that suggests there's very few people, unless you have extremely severe disease, that there's reason to keep on the high dose for over a year. And if that's the case, if you have a $250,000 cap just on 20%, you're probably looking, if you do, and I'm just doing the mathematics in my head, but you're probably looking at about 16 or 17 years before you would endanger that cap. Literally 90% of the people have an extremely good situation in terms of coverage, in terms of the way they change their policy over, in terms of what their copay and personal out-of-pocket expense is, and the way we can work with that. Now, you may be aware of the program that Genzyme has in place right now called the CAP program, Saturdays Access Program. And this is a program that if you are uninsurable because of a pre-existing clause, if you can't find alternative coverage, if we can't find you alternative coverage, then we provide the drug-free. And there are patients on the drug-free right now. What we're doing to even further that, or we're not doing it, actually the National Gaucher Foundation, and this is being headed up by Michael Epstein, who's the president of the National Gaucher Foundation, and I think they hope to roll this program out to at their national meeting in Newark, New Jersey in November. I believe they'll have it in place by then. They're actually rolling a program out called CARE, where they can, out of a fund, supply premium cost, premium increase cost, alternative coverage cost directly to patients who before were uninsurable. Now, what does that mean? Most of the states, and Florida isn't one of the best. When I get done, maybe Leanne can address some of the legislation that's going on in Florida now. But most of the states have what's called a high-risk or open enrollment program, where by law, they can't turn you down because you're a pre-existing disease. That's why they exist. And Florida is working on that now, and I think Leanne's more updated than I am. But under that law, if you have, for example, if you're a small employer, or you work for a small employer and you're afraid either of your employment or of endangering the premiums of your colleagues, this program will be able to pull you out and find a high-risk or open enrollment program. If those premiums are very restrictive in terms of what you can do financially compared to what you paid before, this program can supplement that for your premiums and buy those for you. If you are about to reach your lifetime maximum, before you, including losing all of your medical costs, before that happens, not just when you run out on Saturdays, but before that happens, they can find alternative coverage through open enrollment or a high-risk program. And if they do that, then you'll never lose any medical coverage. They have to accept you. Again, if those premiums are prohibitive, this program will pay for those premiums. And it's going to be independently run by the NGF. They will probably use actually a third party to review the application process. I don't know the logistics. Michael Epstein will present it then. And I think the bottom line to this program is to answer any questions that aren't answered right now. And they've already done their due diligence, checking out through Washington the legality of this and the ethics of this. They've gotten the flag, the green flag to go ahead with this. And it's a program not unlike Amgen has right now for people on Neupogen, in terms of being able to provide insurance for those people who can't get insurance. And that's exactly what this program is to address. The chance that the American healthcare reimbursement system is going to look like it does now 5 or 6 years from now is pretty unlikely. I mean, we all may be covered a different way. We all may be federally covered. I have no idea. But obviously there's change that has to be done. But between what's really out there now for 90% of us and what the CARE program and the CAP program can address for those that fall through the cracks of these, the bottom line is our commitment is for, again, if a physician deems this drug's necessary, you have to have it. We've said it publicly, we have to back that up. You cannot morally and you cannot ethically bring a product to market that this can have this kind of impact on people's lives and not make it available. And if that's too altruistic to accept from a company standpoint, it would be extremely stupid business for us to bring a product to market that compromises the financial integrity of the patient or the third-party payer system, because in a few short years there would be nothing for anybody, and we can't do that. That would just be impossible. The best news is, I think, most of these problems go away because most of the severe patients now are on therapy. Most of the severe patients have had their doses reduced, and most of the patients starting therapy now are of a milder nature. And therefore, these giant costs and these giant doses are going away. Hopefully 2 years from now, there's not going to be any such thing as $300,000 or $200,000 or even $100,000 a year cost. So lifetime maximums and that type of thing will settle back down to not be a real scare. And the fact is, the data shows that right now. Like I said, the doses come down by over 1/2 in 12 months. And almost 80% of the people have had their doses halved in 12 months. Greg Grabowski at Mount Sinai has now got 5 patients with 88% dose reductions. So the most important thing we can do scientifically is give people like Dr. Weinreb that kind of data where they can judge the best way to get you the most effective, cheapest therapy possible. We're meeting with many of the medical directors of the insurance companies who are tied directly into the employer policies. And we're going to show this data. Probably what has been remiss on our part, the most important data to show both employers and insurance companies is the incidence of this disease. I mean, the reality is there's only 2,000 to 2,500 people in this country that will ever need this drug at one time. And if that's the case, there's nobody who stands an extreme amount of liability simply because it is per patient. But as far as what the employer is covering, or as far as what the insurance company is covering, it is not an extreme amount of liability. 96% of the patients who have called us, who have called our reimbursement people, have gotten coverage. And 95% of those people are on therapy. And that's what these people do. They find a way to get you coverage. And even if you're afraid of this thing in terms of the cost, call them up, let them take you through your own scenario with your own insurance policy before they talk to anybody, your employer, your insurance company, or anybody else, and let you know what your situation is so you're informed to make a better decision. They don't have to tell anybody. Their whole job is to hold your hand, if necessary, your insurance company's hand, and if necessary, your doctor's hand to lead you through this whole process. That's all they do. We have 10 people doing that.
How could I find out how much of my cap has been used up?
Okay. Normally, they will only tell the actual subscriber yourself. I could try to call and ask for you, but normally they will not give that type of information out to anybody except the actual subscriber. What you can do is call the claims division, it's usually an 800 number, and ask that question. If you don't get an answer, they may tell you they can't give that over the telephone. You could write. But you have an obligation to know.
And they have to tell you.
I mean, you have a
A
right
matter
to
of
know, they have
fact,
an obligation to tell you.
if you do find that out, we actually ask our patients to find that out. And then what we will do for at least the Ceridase portion, how from that point on it affects the cap, we will track that for you. So we'll let you know what your cap status is on how it stands. But that's something you should definitely find out. And remember, you're the owner of that contract. You're the one paying for that contract. And they have to tell you whatever you want to know.
Is there any possibility that there might be a development of some kind of a synthetic which would reduce the price of Ceridase as it stands
Okay,
today?
we're hoping sometime in 1994, what's called a recombinant version of this product will be out. And this is, you may have heard of this DNA technology, this gene splicing stuff. That's the form that we hope to have available in 94 for one simple reason. The tissue supply is limited. They can only supply drug for so many patients worldwide. Now, if I sat up here and told you that's going to be less expensive, as expensive, or more expensive, it would be an out-and-out lie because we don't have a clue. There's three things in recombinant technology that are basically the challenges of recombinant technology. The easiest thing is cloning and splicing the gene being that thing that we find that makes people make glucocerebrosidase, what the Gaucher patients don't make. Okay, that's simple. The second, the hardest thing, was finding where that gene is in the research area. The hardest thing, without a doubt, in all this type of technology is to bulk this stuff up. We just broke ground on a $75 million plant to make recombinant GCR. We don't even know how we're going to bulk it up yet. We don't know what it costs. I assume the public pressure, the legislative pressure, is strong enough. It certainly better not be more expensive because we won't be able to handle it. So we have to find a way to make it less expensive. But let me suggest this to you. Even if we can find a way to cut 15% or 22% or 31% off the price of this drug, that compared to what we can do with well-controlled studies to get this dosage down by 60% or 70% or 80% pales in what it will do for the cost of the therapy. The most important thing we can do is get the people who need the drug on therapy, and then in the future get people on the drug very early when they're diagnosed, where they don't have severe disease symptoms that we have to reverse, and we can start them out on very low doses that don't cost so much. And I think you will start seeing the literature, and Dr. Weinreb will start seeing the literature suggesting that. There is going to be several publications coming out over the next year. One is actually relating genotyping to phenotyping. Now what that means is they can now take a look at what your genes say and guess what you're going to look like clinically over the years. They couldn't do that just 2 years ago, and now they're getting very good at that. So if a baby is born and has a certain genotype that suggests they're going to be in trouble in just a few years, they can start dosing that baby in minute amounts so that never happens in that baby, so they don't get in that situation. If they have a genotype that shows a very, there's a genotype called 370 homozygous, just the terminology they use, which is a rather mild type of the disease that dominates in the Jewish population, which usually doesn't show symptomatic effect until the late 20s or early 30s. In that case, if they're born and you genotype that, you probably wouldn't start therapy until sometime when they're about to manifest symptoms. But it gives us a great control of the disease. There should be no sick people left on this disease in 2 years. The people that are sick, hopefully we've done something for, and the other people, we won't let them get sick. And that's the whole goal. And if we seem aggressive on this, we are, because it works. That's what makes it fun. It does work, and I think that hopefully the people that are on it know that. There's another study going on that's dosing people at 1/6 what the original study did. They're giving them 10 units per kilogram per injection instead of 60. And you're on that?
Our son's on it.
Okay. In the original trial that was published in the New England Journal, the 12 patients that what led to getting Ceridase approved was all patients responded in terms of their hemoglobin and in terms of their organs shrinking within a year. Within 6 months. In the pivotal trial, in the trial that got this approved, within 6 months, in terms of what they looked at hemoglobin and how they looked at organ shrinking, which is mainly the spleen, all patients responded in 6 months. Now in this new low dose, 75% of the patients responded in hemoglobin, and 25% have responded in their organ shrinking. Now, and Norm has very strong data that probably doesn't make this drug near as complicated to work with as a lot of people try to make it, and that is pretty much you put so much of this stuff in and so much of the fat comes out. And is basically, I think, the way he's trying to simplify it. And what this low-dose study tells us is, and I'm not the Dr. Weinreb's the one to talk about this, is you have to treat every patient like an individual. Everybody's going to respond differently to every dose. That low a dose may be an inappropriate starting dose if you need to reverse symptoms. It looks like it may be a very effective maintenance dose once you do reverse the symptoms. And that's good news, because again, that's 1/6 of what our current dose is, which means to you 1/6 the cost and 1/6 to the insurance company. Other pieces of information that will be published. Those same 12 patients, again, the pivotal trial patients, their bones were looked at very close up at Harvard in that trial, but the data wasn't released at the same time. That data is going to show, I think, the most frightening part about this disease, and that's the bony involvement. People see distended stomachs, and that's very easy to see. People can be very tired from anemia. That's very easy to tell. But things can be going on with the bones that people don't know for a long time, and that can be a little scary. And what this study shows is if you look at the bones other than just a plain x-ray, like a lot of people might, or even a plain what's called an MRI, a qualitative MRI, which a lot of people might, you can look at a Gaucher patient over a lot of years, whether they're on therapy or not, and you can't see a very good change. It's much easier to see in children. Children's bones are in great shape because their metabolism is running, the Serodase works on them better, etc. What this study is going to show is the bones are deteriorating from the inside out, so to speak. And that can't be shown on some of the normal ways people look at bones. And I think what that data is going to show is the deterioration rate of the bone might be a little faster than what we thought before. It's even showing that more significantly than the repair rate with Serodase. Now, one thing I do want to caution here, if tissue dies, if spleen tissue dies, or liver tissue dies, or bone tissue dies, Serodase is not going to do anything for it. We can't reverse dead tissue. This is why children are in such great shape. If children start getting treated and their bones are still active, it literally can almost bring them, they're almost, if they start therapy before they reach puberty, they can just about come back to normal. And that's a wonderful thing. But I think what this is going to show, again, is a very good reason to treat as early as you find this disease. There's no reason to let any of your bone deteriorate and any of your liver die and any of your spleen die before you start therapy, because that's something you can't reverse. And again, hopefully doing that, we can start on a much lower dose than what we are now. And I am glad to report, like I said, probably 90 to 95% of the most severe patients with the disease are on therapy now and are on a dosage reduction schedule. There's falling out about 3 ages that people get diagnosed. The serious gene mutations get diagnosed very young in children, so from ages anywhere from 3 years old to maybe 10 years old, the children are getting diagnosed, and that's good because they need the most help if their symptoms are onsetting then. But also they're in the best shape for what Serodase can do for them, and maybe in the future gene replacement therapy. Then there is a phase around the late 20s or early 30s where a group of patients are being diagnosed. And that correlates with the major Jewish mutation of the 370 starting their onset of symptoms. And then there is where in the late 50s to early 60s, a lot of people actually are that long before they're diagnosed, that are also the 370 who are not manifesting until that time in their life. And very solid data shows that between 1 in 10 and 1 in 12 Ashkenazic Jews, which is about 98% of the Jews in this country, are carriers of the disease. Very, very strong data shows that about 1 in 450 of those people actually have the disease. They have both genes. All it means is they have both genes. Now, we've just gotten some data, actually today. We need to go back and compare the demographics that are going to show probably between 10 and 20% of those Jewish people will actually have symptoms based on their genotype. Now, what is that? And if you figure there's 6 million Jews in this country, that comes out to somewhere probably between 1,300 and 1,900 Jewish people with that'll actually ever need treatment with the disease. Probably about half that many of non-Jewish people will. There's about 1 in 100,000 that are actually affected by the disease. And that's a guess. Whenever you hear somebody say anything over 140,000, it's a guess. But what we are finding out, there's not very many mild mutations in the non-Jewish population. The non-Jewish people tend to have a more severe form of the disease. So more percentage of those people would actually, of the 1 in 100,000 are affected, a larger percentage, maybe instead of 10 or 20%, maybe 40 or 60% would actually need therapy. And so that brings our total number probably somewhere between 2,000 and 2,500 ever in the United States. And maybe not that many, not even that many in the rest of the world.
If I have Gaucher and my husband is not a carrier, my children will not be carriers, or my children? I'm still not quite...
They will be carriers, but they won't have...
They can be carriers, but they will not get the disease.
Correct.
However, since they can be carriers, is it possible they would give it, the disease to their children, or only give the carrying proportion?
No, it's a very good question.
Going through a lot of generations.
If they marry another carrier, then they have a 1 in 4 chance of giving their child the disease. There's a 75% chance they won't.
How many people know about autism?
Last research we did 2 years ago, the average pediatric residency spent, in a 3-year residency, spent 45 minutes on lipidosis and 5 minutes on Gaucher disease. Now, where does that go in their mind? As they go through and they see zillions of kids with other things, it goes away. And I think, and this is no more than a gut feeling, this comes from the NGF2 and the responses they're getting, the noise level is starting to rise now. They just screened 12 million people in Los Angeles for this disease. Through the LA Times, through all the Jewish journals, 4 treatment centers got together. They offered, they put it on TV, they offered enzyme-related testing. They've got 60 people coming in next week for blood tests who may have never even known where to go for this.
We have to do that.
Why don't they do it in Florida?
One of the big puzzles in this area is where are the patients? If we say that there are approximately 2,000, give or take, in the United States who probably are severely ill enough to require Ceridase therapy, and if this is, again, excluding the non-Jewish part of the population just because of statistical analysis, but if this area represents approximately the 3rd largest Jewish community in South Florida, I'm talking about Palm Beach, down south, represents the 3rd largest Jewish population in the country at the present time, we would expect it probably should be lowballing it, I would say 400 patients somewhere around here. And look at you in the room over here. This is virtually represents almost a big chunk of everybody in South Florida who has any knowledge about it.
Would it not be feasible for Genzyme to suggest or do something to get a clinical study started, as they do in Los Angeles?
Well, first of all, there's the clinical studies.
I mean screening study. I mean clinical.
We will support any of that. You have to remember, we're the bad commercial company. The perception of us is we're evil. It's all self-serving if we do anything like that. No matter what, even if it isn't, you can't escape that perception. It's much easier to do something under the auspices of a National Gaucher Foundation or a treatment center. Now, we will certainly be more than happy to sponsor those activities, but it's much more credible if it's not driven by us.
When I had the test about 20 years ago, they did a bone marrow test, and now I understand you can do it with a blood test?
Well, you can. There is
an enzyme?
Yeah, there's kind of a it's called an enzyme activity test, and that means how much glucocerebrosidase you have in you working. And you can at least start out without doing something as invasive as bone marrow. Just do an enzyme test, and if this was kind of a scale, and if you have the normal amount of enzyme activity, you're up here on the scale, And if you're a carrier but not affected with disease, you might be like here on the scale. And if you have the disease, you might be here on the scale. So what you see what happens is it's not a conclusive test. However, if you don't have the disease at all or are not a carrier, it's conclusive. Or if you have the disease, it's conclusive. What's not conclusive is if you're a carrier, but then you can go to a genotype, which is still not an invasive test, and that will tell you whether you have the disease or not.
When somebody comes in who you suspect may have Gaucher's disease for a number of reasons, especially again in this area where we tend to have not so much of the pediatric age group, but we're dealing many times with diagnosing patients who are 50, 60, higher even, and their presentation, or that may alert somebody who's knowledgeable to their having Gaucher's disease, may be either an anemia or an enlarged spleen. There are, of course, many other conditions, medical conditions, which have nothing to do with Gaucher's disease, which can cause very similar findings. And under those circumstances, sometimes, frankly, doing studies such as a bone marrow study is a much more efficient and much more rapid way of knowing what you're dealing with, rather than necessarily sending off an enzyme test, which is specific for this diagnosis. But if it turns out to be normal, then you have to start from square zero again to make the right diagnosis.
Our health care bill in this country in 1991 was $721 billion. That's what health care was, probably the largest single ticket item. The drug cost in this country in the same period of time was $39 billion, or 5.5% of health care cost. That's all prescription drugs. That's antibiotics, painkillers, Serodase, you name it. Since 1960, drugs have been somewhere between 5 and 6% of healthcare cost. I guess the point I'm making here is, whether it's orphan drug legislation, whether it's controlling cost of drugs, we aren't going to take care of our healthcare bill by attacking drugs. We still have 95% of the problem left. The problem we may have, in my opinion, is managing the technologies. We have literally every other hospital in the country with a cath lab and a surgical team standing by when it may not be necessary if you think about it, and those type of things. But we really aren't going to get there. Now, going back to the numbers, Serodase last year was 0.1% of the drug bill, which was 5% of the national health care bill. It's incalculable of what Serodase is costing in terms of society. It literally is incalculable. When everybody that needs this drug's on therapy will be 0.4% of the drug bill, which will still be 5% of the whole health care bill. So from a social conscience standpoint, we don't feel we have anything to apologize for. We feel if the Orphan Drug Act wasn't there, we wouldn't have treatment for people with Gaucher disease today. Another point I want to address, and that is Genzyme gouging us with the high price of this drug. Enough, the best answer for that is, with all the pressure there is, the fact that we can't lower it may be the easiest answer I give. It takes 20,000 placentas to make drug for one patient for 1 year. We then pay a royalty on that material. We do 28 purification steps for that material. It gets bottled in New Mexico. It has a 1-month quality assurance program to go through. It's a stupidly expensive drug to make. This drug cost us $2.97. We sell it as per unit. We sell it at $3.50. That's about a 16% profit. That's the whole story there. I don't know how many of you, if you run your own business or know what the profit margins are, et cetera, of a normal business. This is very, very low in the pharmaceutical industry. And why is the pharmaceutical industry high? Because the pharmaceutical industry puts about 40% of their profits back in research. The average industry puts about 8% back. So that's why they run higher profits. Of this 16%, it goes to gene research therapy, it goes to cystic fibrosis therapy research, it goes to wound healing therapy research, it goes to wound adhesion research, Fabry's disease, several things. We don't feel in any way, and I think even the OTA report, whether they find this the price or not, will show that there's not gouging going on here. The best thing we can do, again, is get good, pure clinical data on how this drug should be dosed most efficiently. And that's the best thing we can do in terms of making sure everybody's being treated fairly and priced fairly.